I'm going to now Mark Shepherd, the Director of Healthcare Provider Services, to talk to you about what the hospital are doing. Update. Welcome. Do you want this little thing, or because some of us are getting older and a little bit harder to hear,
including me.
Just when you want that, just let me know.
Oh yeah, good. So,
Do you want that on now?
yeah, please. So thank you very much, Linda, and thank you for inviting me today. I'm just so impressed that there's so many people here on such a weird, wonderful day out there. The bridge closed and the weather and all the other elements, school holidays and other things that affect us. And I was delighted when particularly Tracy, on behalf of Linda and Maureen and others, asked me to come and talk a little bit, because I kind of see these opportunities as ones you can't miss. The engaging with the community and people who are passionate about our hospitals is so important, and we don't see that happen every day. Although I'm new to Auckland, I'm a Sydney sider, unfortunately, but in coming to Auckland, I've realised just how passionate the community is here in the West around their hospital and their services, not just hospital services, but more broadly, and as you should be. So I really appreciate that. I just wanted to acknowledge also the longevity, the history, and all the good work done by Waitakere HealthLink. I think it's fantastic. The legacy Maureen has created in partnership with you all, and the work that Linda, Tracy, David from our consumer group, Sandra as a board member and chair of our HAC committee, Warren I can see here as well. There's a lot of familiar faces, so I just wanted to acknowledge the great work that's come out of this group and the support for the hospital. And the way I see it is the hospital probably needs that support and needs to support the community. So it's a interactive and ongoing relationship. I think that's probably the key things. When I was asked to speak a little bit today, I thought, well, what are the things you probably would like to know about? And that could be vast and various. And I'm here for a little while, so you can always ask questions. So, you know, at the end of what I've got to present, but so happy to talk about the things that I do know about. But we might just sort of go through a couple of the key things. I thought, obviously, you know, it's been such a disruptive year with COVID. You'd like to understand from a health perspective a little bit more about COVID. I think that was important. You'd want to hear about Waitakere Hospital and what we really want to achieve for Waitakere Hospital, for the community and the population. We want to do that with you and with other community members and our staff as well, because we're all joined at the hip, in fact. The people who often, staff members who work in the hospital often live in the community too. So, you know, there's that ongoing relationship. They're often your neighbours or, you know, your friends. And so it's an important co-design for what we want to achieve for the hospital. And then also the idea about Waitakere as a community hospital, and what would that mean to people, and what are the things that we'd all have to do to achieve more of that integration between the community and the hospital, so it was more at one, I suppose you'd say. And that might just be a little bit more about what's the experience of the community or the consumer like when you come into the hospital, and about understanding that, and how do we make people welcome, particularly the diverse populations that we have in the West, and what can we do to make sure that the experience is a good one and it's effective and efficient and good communication and all those other things. So I just thought there would be three key topics, but I might sort of dive into that if that's okay. So as you know, in Auckland, we've had two surges, or two waves, I suppose you'd call it as well, of COVID, both in late March, early April, when we all went into lockdown level 4 as a community, and also just more recently in August, where we had another surge of COVID patients in the community from the South Auckland region. But that also spread into different parts of Auckland as well, and affected us here in the West, as well as our hospital services. So I might just talk a little bit about the first response, because what happened in the community was vastly different. I think, and this is not just unique to here, but looking at worldwide, we here in Auckland thought in health that we would be facing a tsunami of unwell people. and a high population requirement to go into intensive care. And also, if you look at the rates around the world, the death rate was quite high proportionally for people who got COVID. We didn't see anything like that, and I think that was partly there's two theories. One is, and these aren't my own, this is what the clinicians often tell me, is that COVID is a virus that mutates over time, so it changes. And we've had a lighter strain of COVID. Our death rate in New Zealand and Australia hasn't been as high as what it has been in other countries, like Spain or Italy, places like that. We also haven't seen the hospitalisation rates or the intensive care admissions that other countries have, which is fantastic for us. But also the other theory is that the aggressive approach from New Zealand to go into lockdown obviously then also curtailed the spread. So we're not going to see the numbers that they saw elsewhere. But what we found in our hospital system was that we planned for large-scale change, and we took a lot of our elective work down, particularly our surgery, and made beds available so that we could bring all those patients in, and we trained up a whole range of extra staff in case we needed to open beds in intensive care type spaces, even though we didn't have that many spaces. And it was a very different response. And what we actually found was aged care homes, or ARCs, we call them, aged care rest homes, actually were affected, both in Auckland City and here at St Margaret's, where we had a lot of residents in those homes with COVID, and we had to bring them into the hospital because the staff got COVID as well and got stood down. So it was a very different response we had to provide. We learnt a lot from that, and in fact, we changed our model from thinking that we were going to get very large groups of people into the hospital to recognising it was going to be small, discrete groups of people that were going to come into the hospital. And so we did a whole range of scenario training with just 2 wards at North Shore, because that's one of my other responsibilities, is North Shore as well as Waitakere. And so we had dedicated trained staff to care for those COVID patients if they came in. And on this second wave that came out of the South Auckland area, we had about maybe 10 or 12 patients admitted over the course of the month, and they went to those 2 dedicated areas. So what we tried to do was really contain the positive COVID patients, so it wasn't sort of spread across ranges of staff. We could stand up all of our business as usual, our elective surgical programs and our outpatients programs. We screened people at the front door, so when you've come in here, you might have been screened, and we have a risk tool that helps us determine whether you're a high risk, medium or a low risk, and how we would need to manage you, and whether you can have your surgery or your outpatient appointment. But that way we were able to actually get back onto business as usual and prevent people from having further deferment or further delays in their care. Just an interesting anecdote, a friend of mine is the Chief Medical Officer in Victoria in Australia of the Peter MacCallum Cancer Hospital there, which provides cancer services. And he was on the news the other week, we were talking about it, and he was basically saying to people that cancer trumps COVID. And he was trying to say that 30% of people had not been coming to the cancer hospital for their treatment for fear of getting COVID. And that was just one example where people might stop their chemotherapy or not come for their rate treatment because they were worried about getting COVID. But there's a lot of other diseases that are far worse. And so you still have to get your treatment. With that in mind, why do I tell you that story is because with that in mind, we were very keen to make sure that we didn't disrupt services throughout this last wave of COVID, because we're going to have to learn to live with COVID in the community. And I think, until there's a vaccine or until there's immunity, across large tranches of people, we're going to have to segregate services so that we try and protect all those elective things that we do. It might be your hip replacement or a test on your heart, or it might be your outpatient service, that we need to ensure you get access to care and don't have to stay home because of COVID. So I've been really proud with all the work we've done over this last couple of months to make that happen. And in fact, if you look at our measurements, which I won't go into all the details of, but we're actually delivering more care than we actually had even planned. And that's because we really look to not cancel things, to bring everybody in and get safely provide services and provide care in a very sustainable way. So that's what you'll see into the future, that when COVID is in the community, which it's regressing at the moment, you'll see that there's national alerts change from level 1 to 4. We're in level 2 at the moment in the community. But you'll also see the hospital change to put risk mitigation strategies, I suppose we call them, into place. So we screen people. We know who's a risk and who's not. And that way we can balance the probability around how do we keep everybody safe, how do we continue with all our services, and how do people get access to care for all the other things that they need health services for. That's probably a bit of an overview of COVID. I suppose I might keep going and then come back to the questions, if that's okay. And I'm not sure how long I do have, but I won't keep you too long. So just moving on quickly, just to point out, so we had no patients at Waitakere throughout these last months. We did have back in May, and we haven't had since, and part of our plan is we will just have them in a dedicated ward area at North Shore, so we won't be seeing COVID positive patients here at Waitakere. Clinical services and master site planning. What does all that mean? So I suppose, as I said, most of my career has been in Sydney, and I've managed lots of different hospitals there, and have a clinical background. I was once upon a time a nurse for about 20 years. So I've got sort of, all my adult life has been in hospitals. So I suppose when I came to Waitakere, I thought to myself, really, what does Waitakere need? This is just my impression, because there's lots of people in this room that would have a variety of opinions, which many would be valid. And I really think for the community and the size of the organisation, we really need to recognise that it needs an emergency department. That's quite obvious, because people will get sick. They don't plan to be, but they need an emergency department to respond. We need a general medical unit, which we have. We have a large general medical service here that predominantly, if you were admitted to Waitakere, you're often coming into general medicine, and a great team that is seamless across North Shore and Waitakere to provide with a group of physicians, allied health staff and nurses to provide medical services for you. What we need to build up here is a general surgical presence so that we could provide more general surgery. At the moment, we do what I'd call a low case mix of surgery, which are often day stay cases and only relatively small volume. There are 4 operating theatres here. We're predominantly doing endoscopy. So if you've had those sort of procedures, they're scoping procedures to look for bowel cancers or polyps or any other abnormalities of the bowel, which is great to have that service here. But we also need to expand into general surgery so that if you came in with appendicitis, for example, in through the emergency department, somewhere down the track, you could safely have your appendix removed. That would be something that might be a general surgical procedure. The population here really serves for needing a paediatric and women's health centre. And I would call it, we could even think aspirationally, and again, I'm giving you my anecdotes, but I've shared them with the chief executive and our executive team, and most people have said to me that they think we're on song here, but a centre of excellence for children's and women's health. And when I talk about a centre of excellence, it's something that is aspirational, that other services look at and go, how do we be as good as that service? And that it encompasses comprehensive models of care, so that if you're a woman, say, for example, and many in the room, you could go there and virtually get a whole range or a whole spectrum of different women's health type services, because the population here is, you've got the old and the young, you've got the diversity of mix, you've got people who are young families who are having their children here, and then you've got older people who still require maybe services for menopause or for older age care if required. So something of a children's and women's health service that really puts the hospital more on the map, builds really good reputation, but research and excellence based, I think really sets Waitakere apart. That's something to build toward. There are 2 of the things that we've thought about. If you then think about the site, and many of you have been in the hospital here, it needs a bit of TLC, and I think it needs, I'm being kind, I think, you know, it needs significant dollars put into it. We've been working with the Ministry of Health and the Treasury. At the moment, we've got a short-term plan. When I say short-term, you're talking about 3 years to be able to put another 30, 40 beds on here. But we really do need a full rebuild over time, because the way the hospital was built, you can't build on the top of it, and it's in the middle of the site. So in fact, you can't build around it. There's not able spaces to really build around it. And it's of an aging infrastructure that some of the buildings of the outer perimeters aren't as fit for purpose as they could be. So what we're starting to do to future-proof Waitakere is do a master site plan. We've already done some key components of it, but it needs to be refreshed, and it needs to then get Ministry and Treasury engagement around what are the building blocks that you would see happen over the coming years to build on the backbone, let's call it, of Waitakere, and build it into what it needs to be in the future. So we're starting that process, or continuing that process. We hope to have that 30 or 40 bed ward built sooner than later, because we're already at capacity here. And we actually do have also a plan in place that we're just, Shirley and the team from surgery over at North Shore are building around what does the presence of surgery look like now into the next year or so, while we get that additional space and capacity to actually provide a more comprehensive service. So there are a few things that are on the agenda. To underpin any of the service development that we would want to see here, you really need something like a high dependency or intensive care type service that keeps all hospitals safe, that if someone deteriorated or was unwell, they didn't have to get fast-tracked over to North Shore or to Auckland City. They could be safely cared here. So we need to enhance our services to provide that sort of that clinical backbone for the hospital to be able to bring other services on board. And that's something that we're also in discussion with the Ministry about. So there are just a few things just to explain to you the aspirations we have for the organisation and the clinical services that underpin that sort of development. Part of an example of this, and I won't expect you to understand it, but we have an assessment tool called a role delineation model that helps us understand the maturity or the development of clinical services. At the moment, the blue lines are where Waitakere is at the moment, and the red lines is where we look to aspire to be in the next, say, 5 years, which is about growing services, putting on new services. You can see in the middle, those two solid red lines are the high dependency or ICU type environments that underpin other things. And then other things like laboratory services or imaging services like radiology, about building them into stronger services. A good example might be getting an MRI here sort of thing that would develop the imaging service. So all of those things are on the agenda, but we need time and money and a plan and a whole range of other things to make it happen. I won't go into the detail of this, but there is a regional long-term investment plan that the 3 district health boards across Auckland, counties, Auckland and ourselves have for building additional capacity and building service delivery. So it's not that we don't have a plan, it's about making it come to fruition at the local level for Waitakere. And part of that, the next bed capacity growth we've got 150 more beds coming on at North Shore in 2023 and some more operating theatres. And so the next stage after that really needs to be what's happening at Waitakere. I don't mean we're waiting that long, but that's when you want them delivered, if you know what I mean, beds. Just picking up on child health, I talked about the Centre of Excellence, and we already do have a very strong paediatric presence here, and we don't have a paediatric service at North Shore. It's appropriately located here because the population in the West is a younger population and needs that service, and it's well integrated with the Starship service at Auckland. So we provide up to a certain level of services, and then we might transfer very unwell babies, say for example, to Starship if need be, as does everybody else in the country. But it is very much a hub for our child health services. We've got on-site trained paediatric staff all day and all week. We want to, and we are, expanding our neonatal facility. So what are neonates? Neonates are babies that are born prematurely. And we, on site here, have a plan to expand from our 8 cots, I think it's a 10 or 12. 12. Oh, 12 to 18. Well, okay. I knew it was something about 12. My apology. And that plan is being supported as well by the Well Foundation, which have been fantastic supporters of our organisations. So that's soon to be developed, I think, when we say that finishes next year. That's right. It commences a little bit later this year. So there's a few things like that coming on. Just important that you know that, we're continuing looking to develop things. And the same with women's health. The birth rate continuing to go up. And I think our numbers are something like 4,000 deliveries here a year, which is quite high. It's quite a large service here. We're looking to increase our gynecology surgery, as I was talking about. How do we make the women's health service more comprehensive? We're already providing some services here, but about having overnight beds and overnight services as well for people who need more complex care. Also just extending our hysteroscopy service and our outpatients. There's a range of things like that that are all smaller pieces of work, but they're all building to try and create a more comprehensive women's health service. Central to all of this, though, is that sort of community engagement, because hospitals, we try and be all things to all people, but not every hospital is the same and not every hospital is equal. That's the way I'd probably say that. And what I mean by that is that some have different services that and far more mature. Like most of the tertiary services for the country all go to Auckland City Hospital. So then in relation to that, other levels of service will be provided in the plan to other facilities like around at North Shore and Waitakere. We also need to look at how to engage, particularly with yourselves and other community, through events like this or other community events, through our literacy groups, through our consumer network and our consumer council that's going tremendously well, and other focal groups on particular topics. So say, for example, if we were developing the plan for a comprehensive centre of excellence around women's health, we would get a group together. We'd love the opportunity to co-design what does that look like for the community, not just what health people think it should be, what does the community think it should be? And what does the data tell us? What are the population requirements for that service? So together, those three things hopefully start to build a unified approach to what our services look like in the future. Identifying our consumers is really important, or identification of our consumers. So when people come into the hospital, we recognise that we're there for them, and how do we style our services around the consumer rather than just what the health providers think is best. I think those are important fundamentals. I might talk to this. There's a range of things that are in place around community engagement. And in fact, David Price, one of my team who's here, many of you know, is involved in many of these opportunities, as I said earlier, from co-design work to consumer council and building skills in the community and understanding the community of health needs. I think they're all very important markers of quality and safety. What we'd like to do is kind of style Waitakere more about a community hospital and understand what that means for the community and how do we harness that sort of unique feel that Waitakere has. There's a bit of a saying here you probably all know, which is doing it the Waitakere way, which I think is fantastic because it's sort of just, it's a statement of pride, I think, is the way I view it. Waitakere sees themselves as important in the delivery of care to the community and recognizing that there's a particularly unique relationship here, not just among staff, but with the community, with the patients, with their whānau and another family. We need to be able to harness that to kind of champion a program of improving patient experience. We've all had good and bad or mixed experiences. What I always search for is the reliable hospital, so that if every one of us was a patient that walked through the door, we'd all have a good experience. It wouldn't be left to chance. And that's what I think we all search to achieve. So just in regard to building that sort of community spirit and the community idea behind the hospital, is there's a range of things within the future plan, and offline after we finished, maybe people could talk to David, or through Tracy and Linda, we can always come back about more specific pieces of work here. But part of that future plan is consumer engagement workshops, patient experience champions program from our staff, a co-design champions program, which starts to look at what are the services that we need to provide here, enhancing that community network, and how do we have these days on a regular basis so that we can engage people. The volunteers program for the Westlake Boys and Girls Volunteer Program, that's been fantastic. Only kicked off a few months back, but a lot of enthusiasm with a whole new range of volunteers that are supporting the organisation. And that's probably the key slides I had for today, but I'm happy to answer questions about any of that, maybe in the first instance. Maureen?
Yeah, I don't want to put a sound note on everything because I really support Waitakere hospital. But having a daughter with intellectual disability in hospital at Waitakere for a whole week last year, every day, all I got was, have you signed an non-resuscitation? She's only in a care home. What do you want her to live for? And all that every single day from doctors, which was just terrible. But it's not just Waitakere Hospital, it's right through the country. Anybody with a disability, especially intellectual disability, is not treated as a person. I was absolutely horrified to find that. And if we're going to include everybody as people and look at what they want, there seems to be need to be some more stuff around the medical help that we get. I mean, I still support everything in Waitakere Hospital and what you're doing. I think it's absolutely great, but it's something that parents have to live with all the time. And she wasn't the only one in the hospital at that particular time, and he was treated the same day. It was really hard. Yeah.
I'm sorry to hear that, and it is difficult, isn't it? I'm sorry that that experience was as ordinary as it sounds. Yeah, that's good. Questions? Yeah, it's a good question, and thank you for asking. It's sort of fortuitous because I led the investigation after that. So what it literally happened was we brought 22 patients in from St Margaret's. 6 of the residents had COVID, and we had to bring the other residents in because we were St Margaret's were unable to staff the unit. So there was some spread of COVID amongst our staff then. I think 7 staff members ended up infected. We deal in health, we deal with patients who have infectious diseases every day, whether it be TB or measles or a whole range of other things. And so it's unusual for staff to get infected. So that's why we saw it as an adverse event and that we should investigate it. In fact, in Melbourne, they've had 680 staff infected with COVID inside the hospital. So it just shows how, number one, how virulent it is, despite all the protective equipment, masks and washing hands and all the other things that people can do. There were 14 recommendations. Essentially, when we look at it, and it was without criticism, because this has been a learning exercise, and I think it goes back to what I said earlier, where we had planned for large numbers of people coming and requiring intensive care. And in fact, it didn't turn out that way. There were rest homes that we required to support, there was a thinking at the time when the patients were brought in that the patients weren't unwell, and they weren't. They had COVID, but that didn't mean they were unwell. And they were brought in and put into the geriatrics here because they were older people and they were geriatrics patients. Yep. Looks like my time's up, I think. Did anybody pay the bill? So the assessment of the patients, probably thinking that they weren't unwell and they went to a geriatric area, wasn't really our plan. We were planning for intensive care, lots of patients, and so we didn't stick to the plan. So essentially, there were some lessons learned around what we've done now around our personal protective equipment, masks and gowns and gloves and all those things. What we do is we have a checker. So when you put your protective clothing on, in the clinical staff, when they remove it, that's the highest risk point. Because if you've been infected with the virus, or the clothes have, as you remove them, you could spread it. So we've put a checker in and an auditor in each time in those dedicated areas. And rather than leave it to chance where those patients end up, that's why we've targeted only 2 wards for special training and development, so that they will be able to manage the particular donning and doffing of the personal protective equipment. So in essence, the 14 recommendations all related to stick to the plan, narrow it down, train those people really well, and you won't have a problem. And in fact, I said earlier, we've had 10 to 12 people now in this second wave at North Shore, no staff infections. All those patients have been discharged healthy. And in fact, we've got nobody with COVID again. So we've learnt a lot. Yeah, the jet park. We've shared the guidelines. I don't have line of sight as to whether jet park's using them or not, but we've shared the guidelines that we've developed, and certainly counties and Auckland DHBs are looking at that as well. So it's lessons learned, isn't it? Yeah. Gee, you might let me off easily. I'll take that. Now, look, thank you very much for listening to me. Hopefully there's been some things there that you were interested in, or help give you some insight into the place. And I just thank you again for your support, because without you, we're nothing. So thank you. Oh, thank you. Appreciate it. Thank you very much.